being here this morning for the second meeting of our Position Alignment and Engagement Work Group. So on behalf of myself and Steve Ports and Donna and the whole HSCRC team, thanks to those that are here on the committee, in the room, from the public, on the phone. Thanks for joining by phone. And especially thanks to our speakers for being here today, our external speakers who are here as guests. A couple housekeeping things, just repeat a couple things we said last time. Goal of the system, obviously hit the triple aim, improve quality, improve care, reduce costs. We know that. Our committee, the Physician Alignment and Engagement Committee, our two big aims are gain sharing / pay for performance, develop a recommendation there, and care management related recommendations. At our last meeting, thanks again to Barry Rosen for talking about the lay of the land. We'll come back to that in terms of physician payments and to our speakers that discuss care management. This meeting will focus mostly on gain sharing / pay for performance. We have a number of speakers here to talk about that today. Today will be a very heavy meeting in terms of learning and listening. And I did want to point out that the last meeting and this meeting, we're mostly in listening mode. We're collecting information. The next two meetings are very much going to be work sessions. So I just want people on the work group to know that we're going to take this information and really work through as a group our recommendations in the next two meetings. So after today, we'll be talking as a group more so than listening. One housekeeping thing, we had announced the next meeting on the 27th, but after that, the schedule just said to be determined. The date for the next meeting after that is April the 10th. It's a Thursday, and actually, quick show of hands, I have a question for those on the work group. We scheduled these meetings earlier than the other work group meetings because we know we have a lot of physicians on the work group and thought it might be good for you to be able to get on with your days. So we've been doing them 8 to 10. So the question is, on April the 10th, would you rather it be 8 to 10, 9 to 11, 10 to 12? If you don't have a strong feeling, maybe don't say anything. But does anyone have strong feelings, prefer 8 to 10? Okay, good. Okay, then we guessed right. So good. I don't have to feel bad for having you here at 8 o'clock this morning. We guessed. So we'll stick with 8 to 10, and that'll be on April the 10th, and that'll be posted to the website, today, tomorrow. But that's now locked in. One thing that came up at the last meeting, just want to re-emphasize, is the connection to the other work groups. The other work groups, the data and infrastructure work group, the payments work group, the performance work group have all been moving along. And the more we have each of those meetings, the more we realize how interconnected these things are. The next meeting, we will have an hour by ourselves and then 2 hours combined with the data and infrastructure work group. Came up at the last meeting whether or not we'd do a combined meeting with the payment models work group. We'll have to decide that, but certainly the connections are there. And I also mentioned last time that we're connected to a lot of things outside of these 4 work groups, the MHA transitions, the care model, lots of good work going on all over the state. And actually, thanks, Nicole mentioned at the last meeting that as we're talking about the lay of the land and current physician payments, she mentioned sort of an inventory of lots of different care management models going on in the state. We've gotten helpful things there. That was very helpful. We've gotten stuff from the Maryland Healthcare Commission. That was very helpful, and that'll all be useful starting at the next 2 meetings as we decide to, sort of transition into what do we have to say in terms of writing reports. I think the last thing I wanted to mention in terms of housekeeping, it actually came up yesterday evening as we were talking about gain sharing and pay for performance. As we're saying that is our charge, and when you look at our charge document, it says that's what we're supposed to do is develop recommendations. I reconfirmed this morning with Donna Kinzer that as they were having the discussions with CMS, CMMI, that these were very explicit discussions, that they're waiting for us to get back to them. They know we're a little different. There's some things, for example, they do BPCI in other parts of the country, but the way the law was written, it's for PPS hospitals. We don't have PPS hospitals. So they would expect that we could do something like that. It would look a little different. It would comply with the law. It could be similar. Same way they do ACOs around the country. Well, we have all these people in fee-for-service, but we have this globally budgeted system. So they would expect that we might come back and say, these are the principles exist in ACOs. We want to do it for the fee-for-service population. But the general concept is they're very much expecting something from us. So I just wanted to mention that. I think with that, we are...
Can we do a roll call real quick?
Yeah.
We see who's here for the folks on the phone.
Yep. So we
as well as for D and
yeah. So can we go through the? Here, let me go. Actually, we can just start going around the room to the people on the committee.
Hi, Patrick Redmond from Berkeley Research Group.
Oh, and yeah, and when you talk, please speak into the mic.
Hi, Patrick Redmond with Berkeley Research Group, representing MHA today.
Good morning. I'm David Sharp with the Maryland Healthcare Commission.
good morning, Howard Half with Shaw Associates.
Good morning, Charlie Royland. I'm on the committee.
Hi, I'm Kim Repack, Western Maryland Health System.
Dr. Vinu Ganti, internist, Germantown.
Thank you.
Ben Lowenschritt with Chesapeake Urology.
Dr. Ram Paravemba, anesthesiologist.
Dr. Orly Panich, MEP, Emergency.
Scott Intner, Calvert Health System.
Marlene Riley, Occupational Therapy from Towson University.
Nicole Stallings, Maryland Hospital Association.
Dr. Wayne, Care First.
Barry Rosen. I'm an attorney with Gordon Feinblatt.
Steve Ports, HSCRC. How about folks on the phone?
This is Shannon Isaac. I'm Director of the Doctor of Nursing Practice Program with the University of Maryland and Nurse Practitioner at the University of Maryland Medical Center.
And this is Rich Zummel from the Commonwealth Fund.
Rich Zummel, a physician from Union Hospital, Upton, Maryland, member of the committee.
Thank you.
John Chisar, President of GBMC Healthcare.
Suzanne Dowell, United Healthcare.
Okay. Okay, good. Well, I think with that, we are ready to get going. The last housekeeping point, I think we all figured this out. Speak into the mic. When you're speaking, turn your little, go from red to green. The first thing on the agenda, part will be very short, is I mentioned follow-up discussion on current models and mentioned that we are scheduled to provide a report of the landscape of current physician payment models as well as gain sharing recommendations in a May report. But I mentioned that the next two meetings will be more for discussion. But I just again wanted to thank, like I said, Barry and the MHCC and the MHA and others for providing information. And so we'll get on with that discussion at the next meeting. And with that, we're ready to get going with our presenters today. So the first two, thanks to all those who wrote white papers, the MHA, the Johns Hopkins Health System, MedChi, and Applied Medical Software. Those were the 4 white papers we got on gain sharing. And first, we're going to hear from Patrick Redmond, who worked with both the MHA and the Johns Hopkins Health System on their white papers, and Dr. Paravemba related to the MedChi white paper. So,
Rob, you also have we have Betsy Carrier on the line.
Oh, great. Thank you, Greg. Good morning, Betsy. Thank you for joining. Yep. Okay. So with that, I'd like to bring up Patrick's presentation and turn it over to Patrick.
Thank you. Appreciate the opportunity to be here this morning. We'll let the presentation come up.
Bring it up, Greg.
As Greg is pulling it up, I'll just start with some general comments.
as we've started this demonstration model, I think this has been a long time in the making. There were a lot of discussions on what needed to be in place when we were trying to negotiate this with CMS, obviously, and many of you know the history of it here. But I think from the very beginning, we recognized that this was one of the pieces that was going to be crucial to success under the demonstration model. The moment that we decided to move into a capitated environment, essentially by accepting a growth rate at 3.58% per capita, we essentially accepted a global budget for the state under the new demonstration model. That changes the incentives that hospitals have faced from a volume-based environment where we want to produce more and more to finance capital, drive bottom lines, to the idea of we're going to need to contain our costs and provide care in a more coordinated and a smarter way. I think most health policy observers these days think that that is going to be an improved care delivery model with higher quality, but it's a sea change. And it's one of those things that as you talk to hospital executives around the state and as you talk to folks who deliver care, we've been on the fee-for-service, volume-based incentives for so long, it takes a while to change the mindset. At a discussion at HFMA a few weeks ago, everyone was talking about global budgets, but I was struck by the fact that still many of the discussions had a flavor of fee-for-service, volume-driven care, while, and Kim Repak did an excellent presentation at that meeting, and when she was talking about the TPR experience and what they've had underway for the last few years, the flavor of her discussion was noticeably different. And so I think that, and that's what we want to accomplish under this demonstration, but it will take a while to do it. One of the things that is the biggest problem with the existing system that we've moved into, or that we're moving from, and a new environment we're moving into, is that we have hospitals now on a particular set of incentives, global payments, but for the most part at this stage, some are still in negotiations. But the rest of the system is still largely fee-for-service and is not aligned. Physicians and other providers are still largely paid fee-for-service, and that means if you don't do work, you don't get paid, and that has a very different volume concept there. So that's going to be the gist of what we're talking about here today. We'll walk through the presentation, and I'll be coming back to that theme. But the alignment incentives is going to be the key, I believe, to success under the new model. And therein lies many of the challenges in developing the appropriate incentives for alignment among physicians and other providers. So let me start. The objectives of gain sharing, as I was just saying, is to promote physician engagement, the folks who actually deliver care. There's no hospital executive that admits a patient or delivers specific services. It's the physicians and the professional medical staffs that deliver those things. The hospital administrators provide the environment for that. But so physician engagement is going to be key to success here. The idea of aligning physician-hospital targets is not something that's new. It's somewhat new in the context that we're doing it here, but nationally, as Rob was saying before, we have models of bundle payments, ACOs, and so forth that have started to move down that path outside the state of Maryland. And ACOs that are physician-developed have been doing that inside the state as well, so I don't want to discount to that as well. The idea is there a way for a regulatory system like HSCRC that regulates the hospital system to incentivize physicians to help align their incentives to be successful under this model? There's some major barriers to that we all are aware of, but we'll talk about what we need to do to accomplish that alignment and discuss a little bit the investment and resources that would be required to do that. So on slide 3, in the near term, what do we need to do? Obviously, there are some things that have to be done to accomplish this. I will tell you, when we started this discussion, with CMS a few years ago, much of these concepts were mentioned from the very get-go of the waiver discussions. CMS's response, however, was to note that they themselves don't have the authority to waive the statutes that regulate physician gain sharing, anti-kickback, and the various statutes. It would be the OIG that has to do that waiver. And the first comment that I remember that was that kind of came out of CMS's mouth was, and that will be a heavy lift. CMS is unlikely, I think, to grant us, blanket authority to waive all these things, but they have models under ACOs and bundled payments that are good guidelines, I believe, for any models that we would want to put in place. So there's clearly precedent for waiving some of those things, and as long as you achieve the right outcomes. In the near term, however, while we're waiting for to develop a proposal that would get us the appropriate waivers under the appropriate context for physician alignment, are there possibilities to do something more in the near term? I think that there may be, and some of the things that Kim may be talking about today may speak to that. The hospitals are required under the terms of the new waiver to achieve certain specific targets. There are going to be readmission rate targets that have to be met. We in Maryland will have to be, for Medicare, well actually this is for nation I believe, have to be at the national average on readmissions in 5 years. We're one of the highest in the country, so that's going to be a very heavy lift. We also have to improve the performance on the Maryland Hospital-Acquired Conditions, the program called MHAC here in the state. Again, that requires clinical performance that is not just what hospitals do, it's what clinicians do within the walls of those hospitals. How can we achieve those things? And that's going to require physician engagement as well as engagement along the rest of the spectrum as well. Prevention quality indicators is another area that Donna Kenzer has been very vocal about, and I think is one of the areas where we can improve we can improve relative to the nation in quite a number of ways. For those of you who aren't steeped in the language, prevention quality indicators are measures from AHRQ that were once upon a time referred to as ambulatory sensitive conditions. But essentially, these are primary care sensitive conditions where if individuals get treatment in the community, they don't necessarily need to be in the hospital. When they're treated in the hospital, it's not inappropriate care because the person obviously has gotten to the point of where they had to be admitted. But the point is prevention can mitigate those things. Hospitals don't get paid for that, however. So under a global budget, some of the incentives to take care of PQIs are now there that weren't available under the old fee-for-service system. But that's going to require assistance along the medical spectrum. Again, the need to align physicians is going to be an important part of that. In the long term, we have not just the quality indicators, but also the cost targets as well. As we mentioned, and I'm sure that you guys have already talked about this in great detail, there's a cap on the system of 3.58% per capita growth for the next 5 years to mimic the long-run growth in the gross state product per capita. There's also probably a more important constraint that will be a bit harder to meet, and that's the $330 million in savings that has to be generated from Medicare. Both of those things are heavy lifts. And just to put things in perspective, where were we in the last 10 years? Gross patient revenue per capita in the state was running around 7%. So this 3.58 itself is a heavy lift. With the Medicare additional savings that are required, the hospitals in the state have to become much more efficient. But if we can't live within the context of global budgets and coordinate care better, it's going to be hard to achieve those goals. So I think this is going to be one of the linchpins of success. The next page addresses key attributes. So what are we looking for here in a system that is going to be successful? Well, it's going to need to be all-payer system so that this is an all-payer system. It's the only one that's left in the nation. It avoids the distortions that we've seen nationally for the most part. Medicare and Medicaid pay roughly similar rates to what everyone else does in the nation. So we don't have the huge discounting and wide disparities in payments across payers. That is a great advantage in not distorting the incentives that of the types of services that are offered and so forth. There's no good economic reason for having different payments across different payer groups. However, Medicare and Medicaid, because they're governmental entities and moved in a different way, they've been able to cost shift, and there's debate about all the economic rationales for that and so forth. We won't go into that here today. But Maryland does not face those incentives. The cost shifting is actually prohibited under the statutes that establish the HSCRC. However, that's also the challenge because it's hard to generate specific savings for a single payer like Medicare in an all-payer system. How do we do that? Well, many of the things that we were talking about here, like readmissions and the potentially preventable complications under the MHAC program, are heavily concentrated within Medicare. So that's going to be a good place to start. So if collectively we can work on those, that's going to be, again, one of the things that will help us meet that particular constraint. So when we're talking about kind of the all-payer system and some of the benefits we get out of that, the incentives are applied equally. That's a bit of a challenge in getting the Medicare savings we need. But it avoids some of the disparities in care, some of the access to care issues that are faced nationally aren't there. Medicaid patients in the state, for example, receive the coverage that we have in Maryland is much better than it is nationally because Medicaid is known as a poor payer generally outside the state. Rates are low. Access to care is often difficult. That happens far less in Maryland. And I think that's one of the attributes of the system that we're wanting to save here. Quality improvements are also a hallmark of this. The HSCRC has worked hard in recent years to not only achieve the types of quality improvements that Medicare is producing, but also to get out ahead of that curve. I think the MHAC program, I was in a meeting the other day with a person from Medicare, who was doing a presentation about the waiver, and he actually made the statement that he thought the MHAC program was on quality and on the hospital-acquired conditions was far ahead of the nation, and it's something that CMS was very interested in. So one of the appeals of this demonstration model is the lessons that CMS can learn from it, and that was one that was specifically noted as kind of a crown jewel in the HSCRC system at the current stage. But again, to get there, we've already seen that some of the tasks that we're going to have to do under those, we've had incredible success under MHACs, but under readmissions, we're finding that's a hard lift. And while we've improved substantially, the nation is moving as well. So again, we have to work together as our providers are going to have to help us kind of pull together to do that. If we, for example, still have providers that are incentivized on volume at odds with the global budgets that are available in the state, we're going to have trouble achieving that. So the question then is, how are we going to structure something, a program that will work? It needs to recognize the all-payer system. It needs to recognize the quality targets. It needs to be broadly defined in terms of eligibility, because if we don't have a large number of physicians engaged in this, if only small pockets are there, we're not going to have enough impact to achieve the goals we want. And finally, the distribution formulas to reflect kind of the credit that we're going to need to get is going to be a challenge. One of the things that we're seeing is we're under a limited system right now, 3.58%. That requires global budgets to administer into the way that HSCRC is currently negotiating those. I think the question under these distribution formulas that are going to align incentives for other parts of the spectrum is, will there be enough funds, will there be enough resources to make a difference? Because the HSCRC will not have additional funding. There's a global budget that everyone has to live under. And there are capital needs for the hospitals. There's going to be the investments that hospitals have to take for themselves to better coordinate care. And then also any gain sharing that comes out of that is all out of the same pot. So there's going to be, I think there needs to be a recognition that we have to figure out what the priorities are and how the funding of any gain sharing programs is going to work, and will it be substantial enough to align the incentives as we would like to see. There also has to be safeguards. Page 5 is there has to be safeguards to be sure that we're achieving what we want to achieve. Under any capitated system, there's always the incentive for stenting on services. That's one of the concerns and one of the sources of regulation that CMS has put in place with many of these waivers. there's a whole set of quality metrics, and in our discussions early on with CMS, they noted that any gain sharing arrangements would have a whole set of things around them to be sure that access to care and quality of care wasn't diminished as a result of those capitated features of the system. Further, can this be done in the context of the legal boundaries that are set under the laws that are in place? That's why we would seek a waiver, and that's why we need the specific terms to be aligned in a way that provides hospitals protection for engaging in this, as well as the providers who participate in these arrangements. Let me move on quickly here. I don't want to use up all my time on some of these things. Page 6 just notes the major areas that we have to deal with are the physician self-referral statutes, Stark laws against self-referral, anti-kickback statutes, and the civil monetary penalties for gain sharing are the provisions that are going to be there. And I will leave it to the lawyers to talk about the specific sections and so forth that need to be underway there. But there's a set of issues that has to be addressed in all of these. And I do think that there are models that have showed that gain sharing can be done successfully under this. There's a reference to New Jersey in here in just a moment that I won't go into detail around, but the New Jersey experience has shown that there are some savings possibilities that can be generated from this. On page 7, the exemptions that we were talking about here would allow distribution of shared savings, quality and cost-focused programs, not tied to volume. A lot of physician contracts for physicians that are hired for hospitals before this new demonstration model was put in place dealt with incentives for physicians that were based on RVUs. How much volume were you producing? Under a global budget system, that's not the incentive that hospitals want to be dealing with, because that's not what is going to be effective on the bottom line. If you have capped revenue, spending more resources doesn't increase the hospital's profitability. There are conditions that under the shared savings program that I think that offer us some issues that we need to think about. For example, like ACO eligibility and infrastructure provides some guidelines for us and how we could proceed. Quality targets and quality goals are one way to proceed as well. For example, I think some hospitals have had success with and walked very carefully around the statutory requirements around gain sharing and anti-kickback by structuring very focused programs that have goals that to improve quality, that offer incentive pools, for example, that are not attached to gain sharing explicitly, but to the achievement of specific goals. I believe that may be something Kim is going to talk about in more detail. So there are some models that we can use to look at these things. Let me refer to page 8 quickly here. When we were developing this demonstration model in the state, as we were talking with various folks, we were asking about the possibilities here. HSCRC for a number of years has actually had a methodology that kind of starts down the path of bundled payments and so forth. It's not a bundled payment program, but the HSCRC has had a program called alternative rate methodology that dates back to at least the 1990s. It may go back further than that, but it was put in place with the intent of allowing alternative arrangements from the current rate setting system, so that if there were cost-saving ideas to be developed between a hospital and a payer, for example, that they could be brought into the system outside the existing regulatory, connected to the existing regulatory framework, but to offer a chance for unique savings. It came around in the era of the managed care that was back in the 1990s. There are a number of those arrangements that still exist. A wide variety of experiments have been tried with them. The most that I'm familiar with today are transplant cases, for example, with the tertiary care providers that offer kind of the possibility of joint payments that academic medical centers receive for transplants, along with their physicians groups, and there will be some a specific structure for how those will be compensated, but on a fixed fee basis. So it is possible to do this on a limited basis under the existing HSCRC regulations, but that's fairly narrow and tends to be on a payer-by-payer basis. there's other possibilities, and I mentioned, and like I say, I keep referring to Kim's program because I think that is one where you could have a pre-funding incentive pool that offers a different way of tackling the same issue. But all said and done, those two approaches are probably more limited and more narrow than we need if we're going to make substantial progress. So the third is to propose some sort of broader-based system that would allow broader-based alignment of incentives. And the ACO programs with Medicare probably offer us a model to start with for successful implementation there. You might almost think of this new demonstration model as a macro ACO because we have a capitated system. However, it is limited to hospitals right now. It doesn't bring in the entire continuum of care. The discussion is that in 5 years that may be the case, but for today, the macro ACO is not exactly a completely analogous concept, but it starts us down the path. Maryland hospitals will be required to adopt the same safeguards as the ACO program if we were to, walk down this path, and HSCRC would be kind of the immediate entity that would enforce those regulations. Although CMS clearly is going to be monitoring very carefully, will be putting in place requirements that have to be met under any type of ACO. But it could be applied fairly quickly under the concept of this demonstration model if CMS is so inclined. Let me note on page 9 some of the issues to get ready for this. There are infrastructure requirements that are going to be necessary. Just putting together the essentially the ACO framework, the negotiated framework for aligning incentives and for hospitals to figure out what is going to be available under this to start the process will be time-consuming and a sophisticated process in and of itself. Methodologies for who's eligible and the savings distribution will take some time to develop, and I think there's still a lot of issues around what is going to be sufficient funding to under these types of programs to drive the appropriate incentives. If we're talking pennies on the dollar, the physician care in the state is roughly about 2/3 of the hospital industry itself. So if you're talking only pennies out of hospital budgets for gain sharing, that's probably not enough to move the dial for substantial incentives. So you can see the conundrum that we face as we walk down this path. How are we going to align incentives and have enough resources to do it? Let me move on to page 10 quickly here. So the question is, how substantial are these incentives going to need to be to significantly impact behavior? I think that's an open question at this stage. One of the issues that needs to be addressed as well in the advisory council, for example, the issue of malpractice was raised a number of times. That's one that is somewhat outside HSCRC expertise, but I know that it's one that the physicians are particularly sensitive to, and how that whole framework is handled within the context of gain sharing. What the implications are for hospital malpractice as well as physician malpractice is not clear at this stage. What would the HSCRC role be there is not clear. I know that there were members of the advisory council who were advocating that the HSCRC be an advocate for some change there. That's not my area of expertise, so I won't speak to it. But I think we have to recognize it's going to be an issue that's there going forward. In terms of there were a couple of papers that were put out there. The MHA paper is largely what I've summarized here. Johns Hopkins also put a paper out that largely agrees with all the positions of the MHA. Did just want to comment on one of the points that they were making, though. They wanted to really stress the importance of this resource constraint. I've come back to it several times. Under the global budgets that are being put out there today, that's going to be the biggest challenge we face. How do we align incentives with the resources that are available under the population constraint that's put there? And the Hopkins point was it has to be substantial. It has to be done in an intelligent way. Obviously, it has to be done in a compliant way as well. I don't think anyone disagrees with that. ACOs probably provide the general structure there, but no one really knows, at least as where we stand today, what is going to be required to get us there. So I think that part of this conversation is going to need to focus on recognizing those constraints, but also some discussion about how do you structure these things to turn the dial. I'll stop there.
Hey, Patrick, thank you. Thanks to the MHA and Hopkins for the white papers and having you talk about them, and thanks to MedChi for their white paper and Dr. Paravemba. So, Greg, if we could bring up Dr. Paravemba's white paper, or summary of the white paper.
My name is Dr. Paravemba. I'm Ram Paravemba. I'm a MedChi member, and I'm an anesthesiologist with First Colony Anesthesia Associates. Unfortunately, the MedChi staff couldn't be here, but I think Mr. Redmond's discussion was a perfect inroad to talking about the physician's role, and I know that that's what this committee is all about, is aligning the incentives of physicians with hospitals and other providers around the state. So basically, I'm going to speak to what physicians can do and try to to really nail down the fact that aligning the physician's incentives is going to be critical. And how we do that is going to be the process that we're all going to have to work on, and how we get the funding to do that. But it's going to be particularly important. Integrated practice units is not my own catchword. These are words that were put out by an article in the Harvard Business Review late last year. Michael Porter had written an article, and I had stolen it from him because I felt like that was a perfect description of what physicians can do on a micro scale to build and to create the savings on the macro level. So integrated practice units, you can have the next slide. Basically, the premise that these words are driven by are that physicians and provider organizations are the ones who will innovate and lead transformation. They're the ones who are going to lead and create the savings, the $330 billion that's going to have to be saved in 5 years in Medicare savings. They're the ones who are going to lead the innovations that reduce readmissions, reduce length of stay, and all these parameters that we must meet to meet these goals. And without those innovations and disruptive innovations even, we're going to have a hard time reaching those goals. Patient engagement, education. We need to bring on evidence-based approach to treatment of patients, especially in the hospital setting. And hospital-based physicians will be integral in developing those innovations to drive value in the care process. We also need, the article also that Michael had written at the end of last year in the Harvard Business Review really, and it had been a thought process that I had before I read the article, but we need to focus on specific diseases, specific physicians, specific care processes that need to be refined over time, and we don't have a lot of time. 5 years is not a lot of time, so we need to begin that work right away. So we need to use a holistic, transparent, value-driven approach to care, and also collect data along the way, and we need to be able to build IT infrastructures that may be specific to diseases, to specific patients, specific providers that will need to use that data to continually improve the process, which are going to be different, believe it or not, from the processes that are already there. The SCIP protocols and things to reduce infections in hospitals are great, but we're going to actually have to do more. We're actually going to have to work on processes and look at each step in the pathway in the hospital to see what things are actually happening, what is not happening, what actually makes a difference in surgical site infections and what doesn't, and cut those things that do not have any impact out and add things. So that's going to be a continuous process that's going to require incentives. It's going to require funding. It's going to require incentives. And where that comes from is a good question. I don't have the answer right now, but so I just wanted to briefly describe. I know we don't have a lot of time, but something that we had been working on recently in our hospital, because basically I provide care, so I thought the best way to speak about this is from a care perspective, point of care perspective. Recently, as an anesthesiologist, we've we've been working with the Mayo Clinic, which is a great integrated network of physicians, to see what are they doing there? What are some of the integrated practice units that they've developed? One of the areas that we kind of focused on was colorectal surgery and surgical site infections and length of stay. So is there a way to improve the process such that we can improve those parameters? And it turns out there are. Now, this is still early on, and I'm not going to talk a lot about the clinical nature of what we do, but there are processes to improve care in the hospital to actually reduce length of stay by as much as 48 hours on average, and that's all risk patients, higher risk patients. We may not be able to reduce length of stay by that much. And actually, we've also been able to reduce surgical site infections, which I know is one of the PPCs that people are focused on at this point. So by focusing on a specific population of patients, creating an IPU that's now targeted towards colorectal surgery and stratifying the risk, and creating protocols that are evidence-based, and exchanging information with another institution that's already well underway, we can get earlier discharge of patients. That leaves more room for hospitals to have other patients come in, so that might be a positive. Reduce them by as much as 48 hours, which is substantial. Reduce surgical site infections, which is a contributor to readmissions. All this data is in process. I don't have all. I just put some basic data from Mayo Clinic and things that we could achieve over time. So that reduces readmissions, and also in these, the IT infrastructure is there, so we can have real-time monitoring, hopefully over the short term, if we can get going, to really measure what processes are working, what our readmission rates are, what is the actual length of stay. And this is all driven within a practice of anesthesiologists who we now have realized we need to develop these type of paradigms. The societies, the Urology Society, Emergency Room Society, Family Practice Society are all developing different methodologies along these same lines, and they can probably speak more clearly onto their exact methodologies. So right now there's a focus on costs, and there should be, and also value and outcomes and so forth. The key is that we have to incentivize uptake of these type of independent practice units or evidence-based approaches, and physicians will have to drive it. That's the only way, and there's going to have to be hundreds, thousands of IPUs designed to improve care and produce the value that we're trying to create in the system. It won't come from necessarily all the current processes. We may have to develop new ones, and we'll have to develop them through a robust collection of data and analysis of the data, which can only be then driven in an evidence-based approach by sharing information among physicians and driven by the physicians in the community. The last thing I'll say is, initially there's a focus, let's say, for hospital-based physicians and just reducing costs. There's been some focus on, even from the HSCRC, what we call subsidies and so forth to hospital-based physicians. The key should be not just getting rid of subsidies, but changing them in a way that they provide gain-sharing opportunities, because these subsidies, so-called, are sometimes necessary for, let's say, uncompensated care or undercompensated care. They're not incentives in the current to provide the type of care that I've been speaking of, let's say, with the colorectal protocol and so forth. So we need to take those, not necessarily get rid of them, but convert them into incentives for physicians to improve care. I think the malpractice issue is very important. As a physician, I can speak to that. There's definitely a lot of testing and processes that are that are in place, basically, to basically cover oneself, let's say. And that's clear. And so if we're going to use an evidence-based approach, then we're going to have to attack in that situation. So I think I read through some of the other white papers as well. I particularly enjoyed reading, I don't know, the Applied Medical Solutions white paper. I think a lot of the gain sharing musts on the last slide, basically, some of them are in, similar to what they'll be presenting. So basically, we need to create well-defined objectives, quality metrics that are developed by the physicians and the hospitals. And we need to incorporate IPU-specific and institution-specific quality measures. We need to create gain share opportunities that look at these disease processes, the particular physicians that are involved, and they should be based on the achievement of these specific metrics that are measurable and reasonable. I like the idea of internally having a steering committee. I like the idea, obviously, being a physician that is no less than 50% physician. And I would add that we need to have adequate representation of all those who can make a difference in the hospital setting and outside the hospital as well. And I also agree with a third-party storage and analytic process that can provide the data analysis that would allow the gain sharing mechanism to work. And we're already freely exchanging our data with clinical data registries so that they can analyze the data as well. Thank you.
Okay, Dr. Parabemba, thank you. Okay, Greg, the next presentation to bring up is from Applied Medical Software, and our guests, Michael Callison and Joe Serpin and Anthony Stanowski. Thank you for being here. I don't want to take up time with introductions, but they're truly national leaders in doing gain sharing models and working with CMS. And I'm sorry?
You want to come on up here?
Yeah. Yep. Well, make space for you to come up here. And with that, I'll turn it over to Michael and Joe.
We're well aware of Maryland's unique all-payer system and the important strengths that it offers. Some of you may be aware that Joe and I were of our work with the original New Jersey all-payer system many years ago. And we did note that Maryland recently implemented a 5-year waiver that includes a very aggressive cap. And not to echo what everybody's already said, but obviously effective hospital-physician collaboration is essential to the success under this cap. Gain sharing, as we define it, is the direct payment by hospitals to physicians based on performance. Unlike shared savings, it's based on hospital costs, not Medicare payments. It's a confusion that seems to run throughout a lot of papers, so I'm going to have my colleague here kind of parse that out as we go through what we do. But AMS has designed and developed and implemented large-scale, comprehensive gain sharing programs, all DRGs, all inpatient costs. The model has received 3 approvals from Medicare, including the BPCI Model 1. By directly linking physician incentives to efficiency and quality, the methodology can provide the first major step in transforming provider culture. But this is important because based on experience, the critical date is 6 to 9 months following implementation of the program. That's when the first checks are issued. Our experience has shown that the impact of performance builds from that, but that's the point. And when I say 6 to 9 months, I'm not including the deliberations of the committees, I'm not including the application, I'm not including the approval process, and I'm not including pre-implementation. So I say this so everybody gets a sense of what the real framework is. AMS is inpatient only, but its architecture can be modified to recognize the inpatient impact of population-based reimbursement, and also to interface with other complementary methodologies designed to address the non-acute environment. preparation for today, like you, I read over some of the white papers, and what struck me was that a number of the problems identified in the white papers, for example, free riders and the need for institutional flexibility, are the same problems that we faced when we developed our methodology years ago. Under our methodology, incentives are based upon individual performance. Physicians are not required to join a group to participate, and they are not paid per capita. You can have them join a group, and the group can then redistribute those gain sharing payments based upon the group's rules, but it's not required. And we did that to lower the practical barriers to participation. Methodology provides a direct linkage to measurable results. In terms of flexibility, what's important about flexibility is the ability of the institution to incorporate its own goals inside the methodology. So I noticed that a number of the papers commented on, or actually cited, our equations about improvement versus performance. And for our discussion last night, some of these were really pretty big lifts with Medicare, like the performance equation. The steering committee, which was just commented on, can condition incentive payments based on specific quality and care redesign initiatives unique to the institution. The methodology being extended to consultants and ancillary physicians, but this is the decision of the institution. It's a cost-benefit decision. And there are circuit breakers built in that create a direct link between physician success and institutional success. One final note before I turn it over to my colleague. I don't want to leave a misimpression that developing the, and again, we were talking last night about the OIG list of conditions and what we've been able to achieve. I don't want to leave the misimpression that what we've been able to achieve was easy. Many of these solutions required a lot of persistence with Medicare, and I'll tell you that our discussions with them have now been ongoing for 15 years. So as a beginning point, I think it's really important that we go through what we've been able to accomplish and the details, the policy details behind that. So with that, I'm going to let my boss here take over. You want to sit here? Or?
I'm fine right here. Thank you. And what I'd like to do is you have a lot of material in the handout that was provided and in the slides that provided. I don't intend to go through all of them, but I wanted you to have them as reference, and it really piggybacks off of some of the things that Patrick talked about, as well as some of the other comments that I think will be made today. But Mike has really set the stage in terms of what some of the key issues are, and I really want to go into a little bit more detail as to how you can look at some of those. And I think this issue of shared savings, which Patrick talked a little bit about in terms of the ACO structure, as opposed to gain sharing as it's traditionally known in terms of cost reductions, where you're actually getting savings that are generated from the cost reductions. Medicare is very specific about this, that it doesn't look at gain sharing as a shared savings program. So I think one of the things that we'll try to outline for you, since we have gone to the mat with Medicare on several of these, particularly with Model 1 as it's constructed now, I think the more you can look and feel like some of those things that Medicare has approved, the more success and the ease of implementation you may have. But there certainly are significant differences here in Maryland that it's not one size does not fit all. So we want to make sure that we recognize that. So in the handout, you'll see a lot of information about who we are at AMS in terms of our background. Mike talked a little bit about that, but I think it's important if you look at page 7 of the materials that you'll see some of the projects that we're working on really go to speak, I think, in terms of the breadth of this, and I think in terms of the acceptance of the medical community in all of the hospitals that we're working with. The New Jersey program started out as a demonstration project back in 2009 that was originally with 12 hospitals, has now expanded up to 23 hospitals in what's referred to as Model 1. This was just implemented recently, but I think what you'll see with all these programs is the types of success that we've achieved has been pretty consistent with all of them. In New York, through the Greater New York Hospital Association, we have a program that's focused on non-Medicare patients. It's what we refer to as a commercial program, and that's in 14 hospitals now, and the same type of thing, and it's a good mix of academic medical centers as well as community-based hospitals. So I think we're really starting to see that this is the type of thing, particularly with the level of physician involvement, to get to some of the things that the Medical Society was concerned about. You know, we really have seen that to be important, that this has to be driven with physician input, and that it is critical to the success of the program itself. So page 7 just really talks about some of those programs. I'm going to jump to page page 9, where we really get into the notion of the ACO. So as Patrick mentioned, in terms of some of what you might want to look like, I'm starting to think it may look more like a hybrid program, that you're going to have some ACO-like features where you're talking about capitation and shared savings, and then you still need to have the gain sharing component, which would really focus on the inpatient cost reductions, and that becomes a source of funding for much of the physician incentive program. But one of the downsides to the ACO structure, although we're starting to see mixed success in terms of the literature that's coming out, not just on the Medicare programs, but also on the commercial initiatives, is that they take a long time to get up and running. And as Mike outlined, one of the concerns we have is the time that you have in order to generate some of these savings. So I think we need to look at it, but I think we have to be careful in how we look at it and really be realistic in terms of those time frames. So if you could just click the next slide. So what we see is that ACOs is more of a structure. You need to put a structure in place in order to do that. And that's good. No, back up. There you go. But once you start thinking about gain sharing, and here's where that good distinction is between shared savings program, ACO, gain sharing, which is more of inpatient cost reductions. And I'll say this over and over again because I can't tell you how often we all get it mixed up. And it's just the terminology is confusing. People use it interchangeably, and we can sometimes get ourselves in trouble. But the notion of gain sharing is really more of a bottom-up strategy, where you're really taking advantage of the hospital infrastructure, creating things like the steering committee, which we have found to be very, very successful and an integral part of the structure. In fact, I had an interview yesterday with people from ARC. They're doing a write-up on our original demonstration project, and even this interviewer noted that the steering committee was probably one of the key features of the program, and it's something that has carried over in everything that we're doing. So even under the Model 1 constraints, and it gets that physician buy-in that you were talking about, which I think is so important. So if you think of it this way, structure versus program, I think that sometimes helps in thinking about shared savings versus gain sharing. So on pages 10, 11, and 12 of the handout, you'll see why you would implement gain sharing. I think you know that already. That's why we have this committee here in place. So I'll just highlight a couple features in terms of that. In order to really get the kinds of savings that you need to drive under this waiver without having the physician cooperation in that process, it will never, ever succeed. But it is both hospital and physician driven. I can give you numerous examples where physicians will come up with ideas in terms of where there might be cost reduction opportunities, but without the hospital committing to some of those opportunities, they'll never be realized. One that's very simple is, if you think about it, you want to have MRIs on the weekend. Well, it's fine to say that that's a strategy. A physician could order the MRI, but if the hospital doesn't make that service available on the weekend and see that it's financially feasible to do that, it's not going to happen. And I can give you numerous examples like that. It really does become a partnership, and that steering committee really becomes the driver to make those happen as to where you see that. So pages 10, 11, and 12 really focus on why you don't want to implement gain sharing. Page 13, I borrowed from Maryland Hospital Association. It's an excellent slide in terms of really what Patrick was talking about before in terms of the volume-based thinking versus going to value-based. But I think what's important about this is there's recognition that there's going to be a gap, that as you transition from the notion of fee-for-service more to value-based services, we need something like gain sharing to fill that gap so that we can really evolve to that and make that happen. So I think this slide really says it all. So thank you for letting us use it again. Page 14 is really just a summary of where you are in terms of this process. But what I'd like to do is take the next few minutes to really go through what the performance-based incentive system is in terms of gain sharing. And page 16 outlines for you what we're learning. That often what we'll see is this takes time. Even with this program on the gain sharing side, which Mike mentioned, you can implement and see results within anywhere from 6 to 9 months once we start. But what we also see is there's a need to get some traction on this. You'll get an early set of physicians that will respond and participate in the program, but there will also be physicians that will sit on the sidelines and say, this is too good to be true. I don't believe it's going to happen. I don't believe the hospital is going to pay me some incentive dollars. So often what we'll see is after the first set of incentive payments go out, we see another round of physician sign-ups. So that's not uncommon, that you will have people that will just be suspect of the program. They've seen it happen too many times. So so that's one thing that's not uncommon. But we do see that typically the savings, the cost reductions that we see at the hospital more than offset the payments that are being made to the doctors. So although we're recognizing for behavior that was already positive in some cases, there is more improvement that's driven out of the system that more than pays for the incentive payments itself. The steering committee, as I mentioned, is absolutely critical. I don't think there's a hospital that participates in this that doesn't see the value of getting the doctors engaged, and it just becomes a tremendous vehicle as part of the program in terms of getting physician champions, both at a department level as well as just within the medical staff community itself, and that always increases the physician engagement. So those are really important things, and how you tie this into existing programs. All the hospitals have performance improvement programs going on already, focusing on some of the things that you outlined in terms of surgical site infections, other things. Tying this payment to those initiatives drives improvement on the quality side, and that is really, really critical. On page 17, we outlined for you briefly some of the experience that we've had in New Jersey with the original demonstration. We don't have Model 1 results yet since the program just started in April, and we just did our first round of incentive payments. And that's a good example. The program started April 1st, and the first round of incentive payments have gone out to the 23 hospitals. Typically what we see is I don't focus too much in terms of the number of physicians that are in the program, but more so, although we have over 2,500 physicians in New Jersey participating in the program, what I'm more interested in is how many admissions those physicians cover. And we typically have somewhere at this point around 70% of the admissions covered under the program, and that's a Medicare-only program. What we saw in the original demonstration, and the reason I put this slide up and want to focus on it for a minute, is that you'll see that the savings accumulate over time. That you will not, and this is really important, and we're being haunted by this now with Medicare under the Model 1 program. Medicare, in the new demonstration project, has required that the hospitals guarantee a discount to payments. And this is something that as we negotiate this next piece for Maryland, I think you have to look very, very carefully at this because that's their culture. They want to see guaranteed savings. Now, you have that in your overall waiver, but this is one where you need to make sure they don't get you twice. Because what we're seeing is that the hospitals are really having a hard time in New Jersey with this. That with the guaranteed discounts that are being required by Medicare, the cost reductions don't start soon enough. It takes time to achieve those cost reductions. So for Medicare, over a 3-year period, is guaranteed 2% cost reduction in their payments. That we don't see that happening immediately at the hospital. It takes time to ramp up, and our previous demonstration proved that to Medicare. So that they accommodated that by saying that the discount started out at nothing, went up to 0.5%, and 1%, and 2%. It's still too steep. That you know, in order to get that traction, you need more time because you need to get the physician buy-in, you need to get the culture to change, and with the kind of culture shift that you're talking about, I think that would even be harder. So I think this is something that to be very, very sensitive to as you move forward with this. But the good news is all the hospitals had savings. All of them had savings that were greater than the incentive payments that were being paid out, and I think that everybody would suggest that the level of physician engagement and that partnership became very, very strong throughout the demonstration. And we're seeing the same thing in New York, which is briefly shown on the next slide. This is a newer project, but you'll see that we have good participation. We have 14 hospitals now in the program in New York, but we're seeing the same type of thing that we're seeing cost reductions. On the commercial program, we don't have any guarantee to a payer in this. The hospital is just paying those incentives themselves. So let me jump into the methodology quickly and give you a sense of how that works and what that means to the doctors. So I'm going to jump to page 21. The program is strictly voluntary. Now, many of the provisions that I'll outline here for you are things that CMS has kind of worked on over the years that would be familiar, and I would encourage you to incorporate some of these things into whatever you consider as part of the Gainsharing program. So the voluntary nature of the program is critical, not only in terms of the hospitals participating, but also in terms of the physicians that participate. You need to open it up to all physicians, but not everybody will necessarily sign up. In terms of one of the benefits of the Gainsharing program was that there was no change in payment. That you could work in a capitated environment, you could work in a fee-for-service environment, it didn't matter. So whatever that structure is, the program can be set up to do that. The other piece that was really important to the physicians is there was no penalties. It's an incentive-only program. So and this ultimately had some additional safeguards that were built into it, so there was no encouragement for a physician to take a case or not to take a case. You didn't really care if the physician felt in their best medical judgment you had to provide a lot of resources to a patient. There was nothing that would disincent that physician from doing what was in the best interest of the patient. If he provided high-cost services to a patient, when compared to the norm that we established, he would just get a 0 on that case. It would not be a penalty. Very, very important feature. So there's no reason to cherry pick where you send your patients or where you don't send patients. The other piece that was really important is that, particularly that in the early stages of the program, length of stay is a key factor in terms of reducing length of stay. It was certainly a big issue in New Jersey. I'm not sure here in Maryland how big an issue length of stay is, but I would assume it is of significance as well. So one of the things that we always had to be concerned about, as long as their doctors were still being paid on a fee-for-service basis, was that you wanted to make sure that as their length of stay went down in the hospital, their income also goes down. You need to make sure that the incentives are sufficient enough to make sure that their income is protected. A key feature of how you structure those incentives. And there will be limits imposed by Medicare on how high those incentives can be. So you need to really find that right balance of how we protect the physician and the hospital, but also to make sure that we can stay within the constraints of the regulatory challenges of those ceilings that are put on the incentive payments themselves. The other thing that was important was to make sure that this was just not a financially driven program, that there were quality measures that were part of it so that we could demonstrate that not only did we maintain quality, but hopefully improve quality. And this is where you get into the customization at the hospital. There may be some standard measures that you want to look at. Readmissions may be a consistent issue across the board, but there will be other measures that will be hospital-specific that you want to focus on. So there needs to be some elements of customization, and we found that on the quality side, that's really where you want to drive that. So, and then providing information to the physicians in terms of the detail that they receive. So page 22 just hits on a few of those points on the quality, the fact that we adjust everything for severity of illness by using the APR-DRGs, which you're already familiar with here in Maryland. An important feature when you're talking to physicians and you're looking at individual cases. You want to make sure that you're looking at a severity-adjusted case, not just a broad grouping of cases. Page 23 outlines for you just the general concepts in terms of when you're dealing with a statewide data set like we would be here in Maryland, similar to what we did in New Jersey and New York. We established a regional data set. So using the statewide data, we wanted to make sure that we adjusted for severity by using the APR-DRGs, but we also wanted to make sure that the norms that we established, the best practice norms, were achievable norms. So we set them at the 25th percentile of the lowest cost in the state. So there were already physicians at most hospitals that were achieving that type of standard. So we knew that it was an achievable objective. We didn't want to set it too high, and we didn't want to set it too low. One of the issues that you'll have to wrestle with is who's eligible for the incentive payment in terms of, we're somewhat limited by the data that's collected on the routine data sets. In all of our projects, we start out with something that we call the responsible physician, which is on a medical case, it would be the attending physician of record, and for the surgical case, it's the surgeon of record. There's a lot of discussion as to how you can bring in other specialties as part of that, since it's not just one physician that necessarily influences all the costs of that. We have added intensivists. We are looking at other ancillary departments, anesthesia, radiology, other things that are more of at a department level, and also other consultants. So we have methodologies for all of this, but quite honestly, most of the hospitals have started out with the responsible physician definition, get their feet wet, see what drives it, and see where the issues are before they start adding other physicians into that mix. But these are all things that you'd have to consider as part of that. On page 24, there's a distinction between the kinds of the components of the incentive that we strike, and I think this was, Mike was alluding to this in terms of we need to drive improvement, because obviously if we don't have cost reductions, we're not going to have the dollars to pay out the incentives. But one of the things that we learned early on is you really do need to have the ability to reward physicians for already being efficient. This is not just about improvement, and as you drive that improvement, you want to continue to reward them for staying cost effective. So we have two concepts here. We have improvement and performance. Improvement is where we compare a physician's cost to him or herself in a previous time period. So it's truly no norms, no external data, just you compared to yourself. That ultimately drives where the cost reductions are. Performance is where we compare the cost of a particular case to a norm that was established. And that, too, is reflecting then, as you get better, closer to that norm. It's not all or nothing, but also then, once you get closer to that, that you're rewarded for that. It's an important concept. CMS has approved it. I don't know that they understand it, but they have approved it. So I think it's something that we continue to need to build into this. On page 25, this is a report that a physician would get, and this really kind of brings it all together. It's a snapshot. It's called a physician dashboard. And what this report is really, this is summary at a point in time. We typically issue our reports every 6 months so that there's enough data to make it meaningful for a particular physician. So we show what their costs are on the far left top part compared to the best practice norm. We show them what their length of stay is for the same cases, and then we show them what their incentive information is, performance and improvement. Not only do we show them what they actually got in that period of time, but we show them what they could have received if they had gotten their cases to the best practice. That's shown in the pie charts on the far right. That's typically where the physicians go. They want to see what they got, what they could have gotten. And once they look at that, the first question that comes out is, what do I need to do to get the rest of the pie? And that's when you know there's engagement. And that's when the steering committee really comes to its important role in terms of really saying, what are the initiatives that we need to do and how do we prioritize those initiatives? We identify for a particular physician where some of those opportunities are. We look at it in terms of cost centers or departments, so maybe their supply costs are high, or they're using a lot of OR time, or their length of stay is high, so we see the nursing costs are high. It's a really good snapshot. Very rarely are there surprises. The physicians know, what they're doing, what they could be doing differently, and this is now giving them a reason to hopefully want to do that. So to me, this is a picture that says a lot to the doctors, typically gets them engaged quite quickly. In addition to that, and there's some sample reports at the back of your packet. In addition to this report, they get a detail of every case that made up this report so that they can actually go back to a chart if they had a question about a patient, and we often will have that occur that they may say, I don't remember that case being so expensive. Why was that? To pull the record, see, oh, yes, that patient stayed 25 days. I forgot that what the situation was. So some of the things that you'll have to really wrestle with as you think about both shared savings as well as gain sharing is what's the data sets that you have available. For the gain sharing component, we really tried to keep it simple. And if you look on page 26, we really made the decision to use routinely collected data. So we stuck with the UB. We recognized that there were limitations to that data set, particularly in terms of physician identifiers. But we felt that we could always supplement that later. We wanted to go with things that were routine, that we could collect, that were auditable, replicable, all of the good things that Medicare would be concerned about. So we also used a ratio of cost to charge structure in terms of using Medicare cost reports, and it was because of those decisions that we were allowed to create a statewide data set and to be able to do that. So that's something here that you're already familiar with. You have that data in place, would really make the implementation of this much more straightforward in terms of some of that. So I encourage you to continue to look at some of those things. Page 27 talks about some of the things I already mentioned that Patrick has gotten into a little bit in terms of some of the legal concerns. As you get waivers on these programs, but by having a waiver doesn't mean you don't have to still be sensitive to the issues that those waivers are protecting you from. So you need to demonstrate in the methodology that you had considered all of these things. So by being an incentive-only program, we've dealt with things like quicker and thicker and stinting and cherry-picking and all the buzzwords that you have in some of the statutes that Medicare and OIG are going to potentially waive you from. But the other things that they're concerned about are volume levels, which is certainly an issue here under your waiver, to make sure that there's no reason for a physician to start referring from one hospital to another, things like that. So there are plenty of safeguards that we have built into the methodology itself that as you get more familiar with some of those measures, you'll see that there are specific reasons as to why those safeguards were put into place. Page 28 and 29 really get to some of the points that the Medical Society made in terms of the quality measures. As I mentioned, I'm a financial person. I make no bones about that. So our interest in the methodology was very much making sure that the costs that we calculate are reflective of the services that are provided. But I also have recognized over the years being involved with this that if you don't have a robust quality program associated with this, it's pointless. That if we can't, I actually now look at this much more as a quality improvement initiative that has a gain sharing component as opposed to a gain sharing program that has a quality improvement component. I think it's really important for physician acceptance of this program that this really is part of any performance improvement initiatives that hospitals have going on. It should be an extension of that work. So there are standard measures that typically Medicare requires you to track and monitor. They tend to be things like readmission rates, mortality rates, because they want to make sure that nobody's doing anything that you wouldn't otherwise expect them to do. But now as we've matured under this program, obviously readmissions has a far greater importance, and particularly in a state like Maryland, where you actually have initiatives that you want to target to see improvement in those areas. So what happens is the hospital then adds a set of its own measures, and some of the examples of that are outlined on page 29. When we first start the program, if you think of these as domains, we'll see that many of the hospitals will start out with more of the efficiency type measures to get the buy-in, chart completion, timely OR report dictation, things like that that are loosely considered to be quality measures. I put them more in the efficiency category. But over time, what will happen is they focus much more on outcomes, patient experience, all the things that in effect most hospitals are seeing revenue reductions on because of the way traditional Medicare pays. They get a readmission penalty, they get a penalty for core measures and so on. So where that might not be directly affecting you in the same way, will be things that you'll want to consider as part of, again, familiarity to what Medicare now does. The more you can look and feel like some of that, I think the easier you'll have in terms of getting waiver approval. So these are just some examples. These are hospital-specific. The steering committee would approve what they are. They would assign a value to it. And these become measures that are used to condition the payment. So we calculate an incentive amount for a physician, but for that physician to receive all or some of that would be a function of how they did on the quality measures. So these are just some examples, and there certainly are more. The other thing I'd just like to cover quickly is really, and we put it under the umbrella of institutional safeguards, but I think it's on page 31. One of the other things that I would really suggest you give consideration to in terms of when you go for your waiver for gain sharing is, again, to look and feel as much like Model 1 as you possibly can. And one of the components under Model 1 that's a carryover under the original New Jersey demonstration was this notion of a facilitator convener. The facilitator is really the group. It could be HSCRC, it could be MHA, whatever the ultimate structure of that looks like, is really where there's an organization that's really coordinating all the efforts of the hospitals that are participating in the program. And that entity is responsible for data collection, being the conduit to CMS. We serve in that capacity in partnership with our hospital association partner to provide all that information, and that really makes it streamlined and much easier for the hospitals to implement it. They don't have to have the conversations directly with CMS. It's really more through the facilitator. So that's outlined for you on page 31. So the other role of the facilitator was the application process. I would assume that will happen because of the way the waivers are ultimately granted. Each hospital actually is the recipient of the agreement in participating in this, but it's the facilitator that coordinates all of those efforts. So it is rare for an individual hospital to have the conversations with CMS, more so the facilitator. Page 32 talks a little bit about the steering committee. I think we've covered most of this in terms of the roles and objectives, but you have that there. And then I'd like to just jump to page 36, just again, because I'm sensitive to the time here. We outlined for you here, starting on page 36 and 37, 38, just some of the issues that we think, as you think about integrating gain sharing into what you have as your global model, some of the issues that we see as part of that. Certainly, potentially avoidable admissions, something that you want to focus on and be able to reward for some of those things. So we think that there are ways to tweak the program and the methodology in order to address some of those things that you've outlined in your areas. I think that there are some issues with some of it. You might not be able to solve all the problems all at once, but I think it's important to recognize that you need to start and build on it, and then really determine what the priorities are. So that one is certainly one that if you wanted to, for example, see certain types of cases no longer be admitted to the hospital, then you would want to possibly not incent those cases in the same ways that you would incent others, and then that becomes part of your shared savings pool as opposed to the gain sharing pool. So I think there's a number of ways that you could look at some of those things. We've talked a little bit about attribution in terms of who gets the credit for the cases, as well as ultimately in terms of if there are types of cases that you don't want to see occurring in the hospital. So these are outlined for you on those pages. But I think one of the things that we really believe strongly in is that a program like this, because of its success, and it has been tested and easily adapted into a situation like this, we can get this off the ground rather quickly. And I think given your waiver, that is of utmost concern to you, that we can, and it's something that gives you a starting point that you can ultimately build on. So as you think about gain sharing and then some of the shared saving types of approaches, I really do think this is a way to fill that gap of going from volume to value. The rest of the handout just talks a little bit about implementation on pages 41 through 42 in terms of, what the needs are at the hospital. None of the programs have added staff. They're all using existing staff. They just take on some additional roles. The steering committee is all voluntary in terms of the and the sizes of those committees really vary, but again, really a key component to it, and a requirement under the Model 1 requirement that was built into the requirements for Medicare. So really in terms of approach, what we're suggesting is obviously once you decide what you're doing, the application process would be is probably the most time-consuming of the pre-implementation task, but simultaneously we would suggest that you would do simulation data so that hospitals would know and physicians would know what the expectations are at the same time, and then you would go into your education and rollout of the program and so on. So those would be all the pieces that we would help you with. And then at the back of the handout, you have some additional reports that we've provided to you as samples, but I'll be happy to answer questions on them if you have them, but I don't want to take the time to walk through that.
Michael, Joe, and Anthony, thank you. Thank you very much.
Thank you.
We really appreciate it. And next, we'll have Tim Repack and Kathleen Schneider. Many of you know Tim is on our committee in the CFO, Senior Vice President, Western Maryland Health Systems, and under TPR and doing innovative patient performance activity. And Kathleen works with them on that project from BRG and has done quality work for a long time. And just in case you're looking at time, I built into the schedule 10 minutes at the end for discussion. We really don't. You can go right up until a moment before 10 o'clock. Then anyone has comments, I'm happy to sit here after 10 o'clock, but I want to respect people's time. So.
Okay. Thank you. Thanks. Just to give you a little bit of background, we've been under TPR for about 3.5 years. And as we went into the total patient revenue system, we knew that we needed to be able to make a lot of changes to our care delivery and the results that we had. And we had to do that with the physicians were the drivers of that. We had established a steering committee, a physician quality council that was made up of a third of specialists, a third primary care, and a third hospital-based physicians. And that group was the group that we used to look at all of our data to help us with the initiatives and the education and the carrying out of improvement areas that we needed. When we started into this, the first thing we wanted to look at was where were the most costs, and we had identified the high utilizers. We had 1,972 people that accounted for 40% of our total costs, and so we had about 5% of our population that was accounting for about 40% of the cost. We had originally talked to our physician quality council about some potentials for gain sharing or pay for performance. And one of the things that we found, and we spent a lot of time looking at the data as far as it was related to those conditions that we wanted to go after, where we thought we could get some, where we had a lot of need, but we also could get some quick wins. It was clear from the discussion with the physicians at that time that to concentrate on the specialists wasn't going to get it, because there was not enough money that we could put into the pot that would make it attractive to them to change behavior. At least with the feedback that we've received. I'm not being. That was out of their mouth, not out of mine. Anyway, so we were looking for how could we put something together that could get a pay-for-performance program. We were not looking to take the time at that time to go for a gain sharing or where we had to go for approval from CMS. So we really wanted to design a program that we could get up and running early, because the alignment is so critical. And the physicians were very quick initially to jump on board to help us under managing under total patient revenue. And then it started to impact their income too. And they said, wait a minute, we got a little bit of a problem here. You're still getting paid, we're not. How do we put something together? So that was the impetus for the focus of our pay-for-performance program. We had established, based on our frequent flyer list, we had looked at the diagnoses that were causing us the most problem as far as utilization and admissions, and also the readmissions. We also looked at our prevention quality indicators, and the diagnoses that were hitting under our frequent flyers or our high utilizers were also where we were falling out under the prevention quality indicators. So we were starting with that. We had developed at the time a Centers for Community Resource that was concentrated on congestive heart failure, COPD, diabetic management, anticoagulation clinics. And when we established those, we established them and made them free of cost so as not to have the barrier to patients. And what we found is for the patients who were utilizing it, we were seeing in the first 6 months, or well, the first year, I should say. In the first year, we were seeing a 28 to 35% reduction in our admissions and ED visits by those programs. Problem is, we couldn't get patients in. The physicians didn't want them to utilize it because, in a lot of cases, they were concerned either that we would steal their patients or that they could manage it on their own. So when we started to look at that, that became the focus of our pay-for-performance program, are those chronic conditions that also fell into those areas where we had developed structures that would assist. When we looked at when we had looked at the information, and the information would say, you need to really be able to target the interventions with the physicians or with the patients that have the highest use. So our program is focused on CHF, COPD, and diabetes. We had over 1,400 patients that had those three conditions. 592 of those patients were the high utilizers. What we found is that a lot of those three diseases, there was a lot of overlap in the patients. 55% of the patients had more than one of those conditions. 55% of the patients had 2 to 3 of those conditions. So we were looking at that. We also found that of this particular patient population, there were 796 admissions under the PQI, under the prevention quality indicators that these patients fell into line with. So the design of the program was based on that, is to pick diagnoses that had high utilization, that where we were falling out on the prevention quality indicators, and where we have seen that if the attention and the education is given to those patients, you can make a difference on it. So Kathleen's going to go through actually what the program itself looks like. We've just implemented the program. It took us a year to design. We just implemented as of January 1. We're focusing it on the primary care physician only at this time, and we're only focusing it on the high utilizer group. So the payment on the pay for performance is for the high utilizers, which we define as anybody who has had 3 or more admissions in the last 12 months. But those 3 kind of conditions.
And those 3 admissions may be for any condition, any medical or surgical condition. So when we flagged the patients that Kim was talking about, the frequent flyers, we looked at every diagnosis code on every hospital claim to identify anybody who had diabetes or heart failure or COPD. But then when we actually looked at who's coming in and out of the hospital on a frequent basis, we looked at any cause admission. So once we understood the population and once we understood how we were going to sort of stratify and focus our efforts on the patients that we thought would be most amenable to having more frequent care management and physician contact, then we really had to answer 3 questions. How are we going to fund the program? What are we going to measure? And then how are we going to distribute the payments? And one of the things, and Kim alluded to this, was when we first started talking about this program, we were thinking about it very much in the context of those centers of excellence and the diabetic medical home that the health system had established, and how can we incentivize physicians to refer patients to these programs so that we can provide more frequent contact, that we can get them in for a bolus of IV Lasix if that's what they need and avoid an emergency room admission. And the more we talked about it and the more we talked with the physicians, we were hearing things like, well, you know, we can provide IV Lasix in our office. We have care management services. We don't need the program. Or we find that the diabetes education component is really helpful, but we don't really need the nurse practitioner. So we really, you know, changed our thinking and said it's sort of a triad model. If physicians wanted to send patients to the Western Maryland Health System program and have the nurse practitioners or the respiratory therapist, in the case of COPD, focus the management and communicate back with the physician, that's fine. If the physicians want to manage those patients and can achieve the outcomes we're looking for, that's great. And if they want to do sort of a shared model where they say, you know, we want to take advantage of the diabetic education, but not some of the other services too, that's fine. Ultimately, what we're trying to do is align the hospital and the primary care physicians in terms of taking these difficult, complex patients with multiple needs and making sure that they get the medical and, in some cases, social attention that they need to keep their condition as stable as it can be. So, and this is certainly not an exhaustive list of every issue that we wrestled with, but these are the key ones, and people have alluded to these already. The funding methodology and then the amount of funding obviously is very important, and we were looking for a balance here. It needed to be large enough that it would be attractive to physicians, but not so large that the OIG might accuse us of paying more than quote-unquote fair market value. So we wrestled with those. The types of measures, are we going to look at outcomes? Are we going to look at process? Are we going to look at all the patients with these conditions or just the frequent flyers? And again, Joe mentioned this relative versus absolute thresholds. Are we looking for point over point in time improvement, or are we looking to compare to some external or internal benchmarks? And finally, then, when we talked about payments, we spent a lot of time talking about which physicians, because in some cases a cardiologist or a pulmonologist may be serving in a primary care-like role for some of these patients. Endocrinology to a lesser degree for Western Maryland. That may not be true in other hospitals, but we did end up going with the primary care physician, A, because we wanted to get the program up and launched and off the ground, and B, because, again, when we looked at why these patients are coming in the hospital, it's not all about the CHF and the COPD. They're coming in for pneumonia. They're coming in for other issues. So really we wanted the primary care doc to sort of hold this person's health in their hands. We talked about paying per physician or per capita, and we ended up with a very patient-centered model, so the payments are all based around an individual patient. And then the final consideration is it an all-or-nothing payment methodology? You either hit the target or you don't, or is there some proration? And we ended up with sort of a blended model on the aspect. So our funding methodology is predicated on assumptions around reductions in these PQIs, which everyone has talked about so far. And in our case, we're looking at a reduction in the total population of 9% minimum to get us to a level of funding that again, we think is going to put enough money in the pool to make it of interest. So for the patients that we looked at with these three conditions, one or more of these three conditions, if the chronic prevention quality indicators, which include CHF, COPD, a couple of different types of diabetes, asthma, I think there are some other things in there. If those admissions are reduced by 9%, the hospital's costs would go down by the numbers that you see on the chart, and then 50% of that is put into a pool for potential funding. So minimum threshold is if the chronic PQIs go down by 9%, if pneumonia admissions go down by 9%, there would be, at the end of the year, $651 per patient available for funding, and if a physician has 3 patients, then it would be $651 for each of those 3. We set a cap for calendar year 14 at 17%, and this is important, again, back to the issue of fair market value. If the PQIs go down by 17%, that takes the per patient payment up to $1,229, and we used as our benchmark, if you will, the fact that in 2009, CMS launched a program for advanced care management where they were going to pay $100 per member per month or $1,200 per member per year as a reasonable care management fee to physicians to, again, to do aggressive care management with these folks. So if CMS says $1,200 is a fair market value, that's good enough for us, and that was our benchmark. The payment distribution methodology really has 4 steps to it. First, we measure the PQIs, and if the 9% threshold is hit either for chronic or for pneumonia or both, then those monies are made available for distribution. There's a table a little bit further on that shows, how that changes 9, 10, 11, 12% reduction. Then we calculate the maximum available payment per patient, which is adjusted to say to measure whether that patient had 1, 2, or all 3 of the conditions, because there was some feedback from the docs that said, if I'm managing a patient who has all 3 of those conditions, that's somewhat more, we don't know to what extent, but it's certainly somewhat more complex and is going to require more of my time than someone who only has diabetes or only has heart failure. Then we measure the patient and condition-specific metrics, which I'll discuss in another couple of slides, and calculate the actual payment per patient. So the reduction in PQIs is on, again, this sort of sliding scale, going from 9%. If they hit the chronic PQIs, that's $428. If the pneumonia PQIs are reduced, it's $222, again, for that $651 per patient, and it goes up. Then we use hierarchical condition categories to risk adjust the scores for the patients with 1, 2, or 3 conditions. Again, because we were looking at these diagnoses across, any kind of a hospital claim, we didn't use APR SOI levels because that's an inpatient-only methodology. And we did not try, well, we calculated a patient-specific HCC score, but we didn't want to make our actual payment methodology so complicated that we had to have an individual score for every patient. So we put those scores into buckets. People that had 1, 2, or 3 conditions, calculated the median for each bucket, and using the people with 2 conditions as the center point, then we said that the folks who had 1 condition had an HCC score that was 39% lower. Folks who had 3 conditions was 22% higher than the people in the middle with 2 conditions. We couldn't apply those exact ratios because the payments didn't work out because the patients aren't equally distributed in the 3 groups. So what we did is we said we would take that $651 per patient, reduce it by 11% for patients that only had 1 of the conditions of interest, increase it by 20% for patients that had all 3. Then we get to the patient and condition-specific metrics, and there's 2 buckets. All patients, regardless of which any or all of these diagnoses they carry, should have a pneumonia vaccine, and we're going to want to see evidence of that from the physician record. This will not be administrative data, or a booster, if that's applicable. If the patient has a hospital discharge during the calendar year, we want to see a post-discharge PCP visit, hopefully within 7 days, but certainly within 2 weeks. And this is one of those measures where we're prorating it. So if the visit occurs within 7 days of discharge, you get full credit for that particular measure. If it's within 2 weeks, you get 50% credit. And then, again, if there's a hospital discharge and if that post-discharge visit occurs, we want to see documentation that a medication reconciliation was done during that visit, and that's a yes-no. Then there are condition-specific metrics, and only 1 for each condition. Again, we're trying to keep this simple to the extent possible. So for diabetes, we want to see a hemoglobin A1C of less than 8. Heart failure, we want to see an ACE or an ARB being prescribed for if the ejection fraction is less than 40%. And COPD, we want to see spirometry results documented. And, of course, there's more behind the scenes because over the course of a year, you're going to have multiple values on some of these things. So we had to make decisions about do we pick the lowest or the highest or the last one, and we went with whatever the last documented record of it was. So if the hemoglobin A1C went from 9% to 8% to 6%, they'd get credit for it. If it went from 6 to 8 to 9, they would not get credit for having it managed below 8. Then we calculate the actual payment per patient, and this is where it gets a little complicated, but what we're showing on this particular slide is a sample scorecard for patients in which 100% of the applicable measures were met, so the maximum payment is available, but showing how that payment would vary based on whether the person has 1 diagnosis, 2 diagnoses, or 3 diagnoses. So in this case, everybody had their pneumonia vaccine, everybody had their discharge visit within 7 days, they all had medication reconciliations done. You can see in the first example, the hemoglobin A1C and the ACE and ARB are not applicable because that patient only had COPD, but they did have spirometry results documented. Category 2, you see now we're measuring 2 disease-specific measures, ACE and ARB and spirometry. In Category 3, this patient had all 3 conditions. And so the per patient payment goes from $586 for the patient with only diabetes or only COPD up to $781 for the patient with all 3. And our last slide is just another set of scorecards. Here we're showing same risk category. So this patient had COPD and CHF, but different scores. So in this case, they didn't hit 100% on every measure. And you can see that in this case, the scores go from the payments go from $651 if all patient and condition measures are at 100%, down to $456 because in this case, in the second column, the patient was seen within 8 to 14 days after discharge rather than 7 days after discharge, and there was no medication reconciliation. And then on the far right, you can see that the payment dropped to $391 because there was no post-discharge visit within the 14 days. So I know that was kind of geeky, but some of it has to get sort of technical as you start to get into the details.
And the thing that something like this did for us is it allowed us to get into trying to align physicians without having to go through CMS or into Gainsharing. We can do it through a pay-for-performance until other mechanisms become available, because we currently don't have a physician organization that we can join an ACO or anything of that sort. We're forming one, but we needed something that was a little bit simpler than some of the others.
And we had legal review all along the way at each step of the process.
The acceptance from the physicians as far as participating in the program, we have about 65% of the primary care physicians who have agreed to participate that have people in these categories.
That was great. Thank you. Thank you very much, Ms. Kathleen. Okay. As I said, so we have a few minutes for questions and comments, and as I said, our next couple meetings are going to be much more discussion focused. So why don't Steve, thank you. Sorry to the people on the phone if you couldn't hear me. I was just saying we have a little while for questions or comments. I noted that our next couple meetings are going to be more discussion oriented versus presenter oriented. So we'll have a lot of time with the next couple meetings to discuss. But for now, why don't we start with the committee members around the table, and then we'll go to the committee members on the phone. If you have questions or comments, especially for our presenters that are here, and available at this time.
Nicole Stallings, Maryland Hospital Association. Thank you to all of the presenters for all of the work that went into today's presentations and to the white papers. One thing that struck me that may want to be reflected in the May report that I heard in particular from Western Maryland and also from AMS was using metrics and sources that are already industry standard. When I was looking at slide 15 from your presentation, Kim and Kathleen, I noted that all of these measures are part of ACO, or they're really tried and true. And to me, that seems a key point, to not try to create something from the groundwork. There's obviously, I heard, if it got approved by CMS already, we should look to do that. If these are metrics that are already endorsed by your hospital or by another entity, those are things that we should look to. And so it seems that is important for two things. One, because we can really waste a lot of time trying to develop metrics and agree on what the one definition of something should be. And sometimes in Maryland, we like to go above and beyond kind of what that standard is and really create something Maryland specific. But for this particular initiative, we may want to really try to look to industry standard. But also, I think it will help us with that physician engagement component. Physicians really like to spend a lot of time talking about those things. So that was a key takeaway that I heard. But and while I very much appreciate the fact that I heard two folks from a financial background understanding and really very conversant in PQIs, and I mean, for a CFO to be able to really talk about that is quite impressive. I keep coming back to where is this money going to come from? And I guess my question is, how does this relate to the work plan for the payment models work group, considering things about the balance update? I mean, where there was a very unique situation where Western Maryland could put aside that $400,000 pool, right? Not every hospital is going to be able to do that now, moving forward with global budgets. And so I'm curious how this really crosswalks with whatever recommendations might be coming from payment models, and with our two next meetings that are more working sessions.
Nicole, thank you. And I would say that your comments about using standards, for those that were here, that's certainly a theme that came up in the last meeting as well. So that's good. And was talked about at the last meeting about making sure that there's the idea of using standards, and then there's also the idea of consistency as we look throughout the various programs, those going on throughout the state already, innovative things being done at different hospitals and with payers as well, that we should, maybe facilitate bringing common approaches so that physicians aren't trying to respond to different incentives under different programs.
Rob, John Chester was on the phone, and he doesn't have audio, so he sent a couple of comments that I'll read if that's okay with you as well.
Fantastic.
The first one is, these are to the organizers and panelists. It says, Patrick, I agree that Maryland should be proud of our system, that our system pays hospitals equally for Medicaid recipients. However, since Medicaid rates for docs are so low, this has pushed Medicaid patients into very expensive hospital-based primary care or hospital-based acute care. This group should think about incenting docs to care for Medicaid patients. And he also mentions the dollars for gain sharing. There are dollars already there. We need to free them up from the waste. So those are the comments that he was forwarding.
Good. Patrick, thank you. And if, John, you can hear us, thank you to you. Charlie?
Thank you also to the presenters. One of the themes that I'd love to hear about, both from the New Jersey experience as well as Western Maryland, is, and it gets a little, I think, to what you're asking about, Nicole, but maybe in a different way. As we improve our documentation, which many of us have been working steadily on for years, what my observation is that the complications don't always go down as much as the documentation goes up, right? And therefore, your performance against an expected rate always gets better. That's effectively a revenue solution, not a cost reduction solution. And in our world where we're going to cap our revenues, that's not really going to be a cost savings maneuver for us. And I'm interested in how you dealt with that both in New Jersey and Western Maryland. For example, in the reductions that you would see in your PQIs, are you comfortable that that's really going to translate to savings to the hospital? Or in fact, is it better documentation of those things that we've always wanted to have in place, and the hospital isn't saving any money and is now going to pay out bonuses for things that have been done all along? It's a long-winded question.
One of the reasons that we like the PQIs, and that I think you hear them coming up, in everybody's presentation, is they're not really coding subjective. They're admission rates for certain conditions, and there are some exclusions, patients under 18, and there are some other exclusion categories. But basically, it's looking at, for example, per 100,000 population, how many admissions are there for pneumonia? And again, as Patrick mentioned earlier, it doesn't mean that those admissions were unnecessary. Those people may have been very, very sick by the time they got to the hospital, but if they had gone to see their doctor, if they had been put on the right antibiotic or any antibiotic, they may not have required hospital care. So it's much less subjective or much less coding driven than MHACs, for example.
Yeah, I guess maybe the New Jersey folks can
Yeah, I would just add to that I think you're right. It's a little bit of both. And from the doctor's perspective, what we found is that data integrity is critical to the success of the program, so that even though improving the documentation helped that data integrity issue completely. So short term, there was some revenue enhancement for the hospitals, because remember, they're paid on a traditional, in New Jersey, they're paid under PPS, so they benefited from improved documentation as well on the revenue side. But that's one-time kind of experience. So I think that the improved documentation really went to data integrity, and that the doctors were compared more appropriately to what they should be doing, and there still was tremendous opportunity for cost reductions. So they really do go hand in hand.
Thank you.
Yeah, I actually want to piggyback on that. And one of the things I think was different about the last presentation rather than the first three was the first three all dealt with the cost per utilization. But the last one actually dealt with the rate of utilization, and that's going to be critical. We're looking forward to the next two sessions. How do we, with the demographics we're facing, how do we reduce the hospital encounters in general rather than just make the hospital encounters that exist less expensive? Because in a lot of cases, there's not a whole lot of room, particularly lower cost hospitals, to crank that down much further.
It's also one of the things that made the attorneys very comfortable with the program because, you know, it's sort of motherhood and apple pie. How can it be wrong to keep people with these chronic conditions stable and out of the hospital in their own home environment? So.
Yeah. Thank you, Scott, for that comment. I think we talked about it at the first meeting that in this new system, it's going to be a lot about volume. I mean, cost per case is certainly important, but it's going to be a lot about volume and incenting the things you say to keep people healthy and out in the first place. Dr. Heft.
Yes, again, thank you to the presenters. Very thought-provoking, innovative models, but both very different. Of course, the AMS model really focused on the silo of the hospital, the responsible provider being the physician in the hospital, which in many cases in Maryland would be the hospitalist, the employed specialist, et cetera, and doesn't really go outside of the boundaries. It's very siloed in that way, and the Western Maryland is very siloed, and it's the primary care physicians and focused on rates of admission and AMS on cost per admission. So they're distinctly different. I'm not sure that they either of them really solve the population problem, which is, or speak specifically and universally to the challenge that we have, which is meeting those specific goals of the waiver. If they both nibble at those, take a piece of it, and the challenge may be to merge those into a more comprehensive system. And just one point of order. I was called to task on a national platform for using the term in a public forum, for using the term frequent flyer. I think it would be good if we deleted that from our lexicon. It is a bit pejorative, and high utilizer or some other more responsible term for patients who suffer over a great deal of disease.
Yeah. Dr. Heft, thank you, and also thank you for sending along in between meetings the principles that you've encountered related to gain sharing. Just because I heard it said a couple times, and then I also heard Michael in his opening remarks and perspectives, I noted that you did mention that the architecture of the AMS program can be modified to look at population-based reimbursement. So I think they were talking about what they've done heretofore for clients that are under the DRG system, and so that's what benefits them. But I think they recognize that under our new global budget model, volume is important, and so I think that's why they put in their presentation that it can be modified to address that, but that hasn't been what has been desired under the DRG system in other locations.
Just a quick question and some early feedback that I've had from physicians. It was mentioned just once briefly that no gain sharing dollars might be paid out until certain quality and quality or access weren't also either maintained or improved. And I think there's been some reasonable talk about quality metrics, and nationally a lot of talk about quality metrics. And maybe this is a segue into next meeting, but the question of access, I think, is a concern for a lot of physicians in saying, or if we are, or underutilization, I guess, also, the access and underutilization, and how is that going to be measured? How are we going to be held to a certain standard for that? And I'm not sure it's, maybe there's some intention that's out there. I certainly haven't heard it here, but I don't know if the data group or someone else is looking at it. But it's certainly a concern if we say we're going to stop, doing certain things the way we've done them before. And we've touched on malpractice concerns and START concerns and other regulatory concerns, but also just how is it going to be measured as far as what access we might be responsible for in utilization. So, going forward, we'll have time to talk about that in the next one.
So I have 2 points. Some of it plays on what we've been hearing. Excellent presentations. So I think what we have to consider around ramping up physician engagement is what are the boundaries, what is the roadmap. We talked a little bit about primary care physicians, we talked about the hospitalists, but there are a lot of other physician types, as we all know, some in the room. When we think about the recommendations, how's the roadmap going to be laid out there in a way that it's inclusive of all physicians, maybe not on day one, but at some point in time. And then the second aspect I would mention is, I think what Nicole started out by saying is some kind of standards around evaluation or harmonizing evaluation standards is probably important, because there'll be some uniquenesses of these programs among hospitals. But imagine if there are 46 different programs all sharing the same sort of concept, it would be nearly impossible to sort through. So if we can think about what are the key elements for harmonizing standards around these programs, that might be very useful.
Thank you.
If I may, Kim and Kathleen, just maybe I missed it, but your program, did it require any approvals? I know your lawyers have been looking at it very closely, but I mean, I think this is one of the, we talked about barriers in the past, and one of the differences is my understanding it required no approval from HSCRC, it required no approval from CMS or OIG. Was there any other level of approval that you needed other than your, working with your physicians within the hospital?
Yeah, because we kept in the parameters of what has been approved throughout the country, it didn't require any CMS approvals or regulatory approvals at all.
Hi, to piggyback off a comment that David made, it is important to look at the capacity with which each physician practices, because there are situations where volume is very challenging. And if, for example, an emergency department, I would completely agree that you would want to shunt some of the volume away from an emergency department, and yet an emergency department needs to have staffing available 24/7 to be able to provide the full range of services that are available. And so critical volume is important to be able to support the ability of an emergency department to maintain practice. And so there's a dynamic there that, you can't split a physician, you can't split a provider, and there's downtime that has to be accounted for in that.
Any more comments from our committee members on the phone?
Greg, do you have anything?
No?
Yeah, I think that one thing to keep in mind, and a question was, how do you fund it? The whole concept is, especially under the global budgets or under the TPR, is right now, if you're able to reduce those admissions or the visits and treat people in a get at the population health to keep them healthier, the hospital retains that money at this point in time. And so there are funds available, but as you get into the programs, that it generates the funds that can go out to pay for these programs. It's not that you need to have additional funding through the rate setting system. That money is already generated by the fact that you are saving monies on the admissions or the readmissions or the ED visits, and you're just redistributing them to use them to pay for these other programs.
Yeah.
And if I could just add on to Kim's comment, because I think that's important, it goes back to that notion of shared savings versus gain sharing. What she's describing would be really more the shared savings part, where you're reducing the admissions or some of those components. But if you then compound that with the gain sharing piece, where you actually treat more efficiently those cases that are in the hospital, then you would have an additional pool of dollars through those cost savings that would be part of the gain sharing incentives. So it's really the coupling of those two things. It's really almost like a hybrid model.
Thank you.
This is Barry Rosen. I thought it might be helpful, I'll put my lawyer hat on just for the group. This notion about whether you need an approval or you don't need an approval. What's going on is there are two laws, and so you're trying to set a course between a rock and a hard place. The rock is you can't pay docs to refer to your institution, and the hard place is you can't pay a doctor not to provide care. So Western Maryland was paying docs to achieve, certain clinical outcomes and not to provide care. and they were paying at a fair market value, which is how they went through that part of the canal. They are a rural hospital, so they don't usually have to worry about splitters. They weren't paying docs who don't normally refer to them. In an urban or suburban setting, you'd have to put an extra wash on this because you don't want to pay somebody who wasn't referring to you now to refer you in order to get the $651. So there would have to be baselines of what people have historically been doing and not allowing them to get paid to split from one hospital that has the program to another hospital that doesn't have the program. But there is risk tolerance in this. In other words, if you don't get the approval, the hospital has to be comfortable enough to assume the risk that a regulator will come and second guess what it is that you did. But at the moment, there is a way to set a course between this rock and the hard place. It's just not as assured as if you went and got an approval for a particular program. It surely would be helpful.
Jerry, thank you. Any comments from any of our other guests this morning? Well, I think with that we're done. I'll thank everyone for coming. Our next meeting is on the 27th, and just note that meeting is from 9 to 12, and the first hour is going to be just ourselves, more discussion-oriented, and then the next 2 hours is a joint meeting with the data and infrastructure work group. And I actually should point out, I kept talking about how much the next 2 meetings will be more discussion-focused. That, when I say that, I mean the first hour of the next meeting, and then our the meeting we just announced, the April 10th meeting. But the second 2 hours of our next meeting, the combined joint meeting with the data and infrastructure work group, there will be a number of experts at that part of the meeting. So thank you.
You know, well, I realized I walked out and left them anyway.